Hi everyone, and welcome back to Making Dad Summit. It's Wednesday the 17th, and we've been just talking about men all week long and the importance of bringing awareness to men's health and men's infertility or fertility issues. And once again, I'm joined with my co-host Sara Naab from Don't Cook Your Balls and Dr. Eisenberg. And today, on Wednesday, we're talking about shooting blanks. And before we jump into that important conversation, I would love to take a moment and just acknowledge and thank our amazing summit sponsor, which is Fairfax Cryobank, which is one of the world's largest sperm bank, offering anonymous and ID option sperm donation, as well as storage services for sperm, embryos, and oocytes, which are eggs. And you can learn more about them at their website, fairfaxcryobank.com. And if it wasn't for their generosity funding this conversation, we wouldn't be able to offer this amazing week of information and experts just like Dr. Eisenberg. So Sara, hi honey.
Thanks, Kristen. I just want to add that, conversations like this about shooting blanks or azoospermia, sperm banks like Fairfax are miracle makers to a lot of families, being able to bring hope in cases where there just isn't the chance for a man to become a biological father. But luckily and hopefully, many men with azoospermia or shooting blanks do have treatment options, and it's just an incredible thing of modern medicine that doctors are able to treat this. And I'd love to introduce Dr. Eisenberg, one of the world's experts who does this. He, on a regular basis, treats men and helps make miracles when guys come in and they found that they don't have any sperm, and he's able to help them identify the cause and find solutions. He is the director of male reproductive medicine and surgery at Stanford, and a researcher really focused on the correlation between fertility and men's health. And so he's just an incredible expert and resource to have with us today while we're talking about shooting blanks. So welcome, Dr. Eisenberg.
Thank you. Thanks for setting this up. Thanks for having me.
Great. Thanks.
So let's start with that deer in the headlight moment. You're trying to have a baby. It's not going so well. You finally get in there. You finally get that semen analysis done, and that dreaded moment happens when you look at it and there's nothing there. And it's probably one of the most terrifying moments of a man's life to just see that paper. What's going on?
Yeah, and it's very devastating to have to give that news to men. But I think one thing that I always try and let them know is it's not that uncommon. So about 1% of all men in the world, in this country, have no sperm. So one sounds small, but that's actually a lot of men. That's millions of men. So I think that's important to know that they're not alone. And the other thing that's important to know is there's a lot that we can do. So just because there's no sperm in the ejaculate now doesn't mean that in the future there won't be. There's a lot of treatment options that we can offer that hopefully will improve it. So the first thing that we look at when we talk about azoospermia or no sperm in the ejaculate is why. And so there's two kind of broad classifications. One is there could be a blockage in the system, so sperm is being produced, it just can't get out. The other possibility is there's a production issue. And so production is either absent, which occurs unfortunately sometimes, but oftentimes what also happens is there's just kind of limited production. And it actually takes sort of a threshold amount of production to occur so that the sperm can actually get out into the ejaculate. So there may be some production in the testicle, but just not enough so that it actually makes it all the way out into the semen. So the first thing we want to do is try and figure out which of those is going on, and then once we have a handle on that, we can talk about some treatment options. So if it's a blockage, we can hopefully try and correct it so that we can get sperm back in the ejaculate, and so then they can use that just to have sex and have a baby. But other times, if it is a production issue, figure out why production is limited. Maybe there's an exposure in the past. We just need to give a little more time for things to recover. Maybe there's some anatomic reason. So there's actually an association between varicoceles, which are dilated veins in the scrotum that can warm up a testicle. I think we talked about that on Monday. So actually one of the first instances of the link between varicocele and fertility was actually a man that had azoospermia, had no sperm in the ejaculate. This was fixed, and then he developed a sperm count after that. So that's another possibility. There can also be hormonal influences that can be optimized, and through that sometimes we can improve sperm production. So I think, one of the important things to find out why, but then once we find out why, we can talk about some of the options. So I think hope does remain, and actually reasonable chances of conceiving, even with no sperm, what we see kind of in the first semen analysis.
So what's the workup like? What are some things that I think doctors, as we've talked about throughout the week, men aren't very used to going into the doctor, and that, it can be very intimidating. What's going to happen? What's he going to do? What's the workup like?
Yeah, well, nothing should hurt, basically. That's the first thing I would say. So if we see no sperm in the ejaculate, the first thing you want to do is just check another one, because about at least 20% of the time, if there's no sperm in the first one, we can find some in the second one. And I think if we find sperm, it really changes the scenario dramatically. Even if there's just a few, I think it gives us a lot more options immediately. The other thing that we want to do is check some hormones. So the testicle does two things. It makes sperm, but it also makes testosterone. So we check testosterone and some of the other hormones involved in that pathway, and that'll help us tease out a little bit whether this, again, it's an obstruction problem, a blockage problem, or whether it's a production problem. And then anytime there's very limited sperm or no sperm, the other thing that we look for is some rare genetic diseases. And so this is another blood test, and this just lets us know, again, likely what's going on, because I think it's always important to figure out the why and how correctable it's likely to be. In addition, kind of depending on some of the different test results, there also could be some implications to any kids. So one thing that we commonly test for, or we always should test for, is a Y chromosome deletion. So if we remember from biology, women have two X chromosomes, man has an X and a Y, and on the Y chromosome there's a lot of DNA that's important for sperm production. And so rarely a little piece of this DNA can be lost, and so that would be the reason that sperm production is not optimal or completely absent. And so if a man has this problem with his Y chromosome and he has a son, his son is going to get this same Y chromosome, will have this same problem. So I think that's important to know. I've counseled men with this deletion many times, and I think there's kind of two main answers. Some men say, well, when my son is ready to have his own family in 30 years, we will have found a solution to this. So I'm not too concerned about it. Let's proceed with having a baby. But other men would say, well, I know how stressful this has been for me. I don't want my child to go through this. So in that scenario, maybe I'd just rather have daughters. And so I think both of those are options. But I think it's very important to get that information. And so I think that, when we do get this diagnosis, it's important that men are thoroughly evaluated by people that are familiar with, the workup, because I think all these different tests and the kind of implications of all of them are very important. And some of them can be quite complicated. So it's just important that, you have some familiarity with it.
So of the causes of azoospermia, is it more common to be a production or a blockage?
It really varies a little bit on the population that you're seeing, but it's probably about 50-50. In general, the common causes of production issues, a lot of men you can kind of pinpoint it, whether it's some of these genetic causes, which contribute maybe about 10 to 20%. A lot of men have a history of, prior cancer and prior treatments, and so they have this exposure in the past of chemotherapy or radiation, and that's a clear cause. But a lot of times, even after we do a complete evaluation, there's no clear cause of what the issue is. And then for blockages, again, sometimes we can clearly identify why this occurred. Sometimes there's congenital problems in terms of development. Cystic fibrosis, thickened secretions in the lungs, that's how it manifests as the disease that we're kind of mostly familiar with the pulmonary manifestations. But it can also thicken secretions, down below as well, and so it could lead to malformation of the vas deferens or some of the other structures in the genital tract that can lead to blockages. But again, sometimes we can't identify a clear cause.
So, Doctor, can we bump back to one of the things that you said, that so you test and then you retest. And
Yes.
so does that have to do with the sperm production?
Well, there's just variability in one semen analysis to the other. So there was a study done a number of years ago by the World Health Organization where they followed one man and they checked his sperm count about every week, and you just saw wild fluctuations. So that's just known for for unclear reasons. There may be lifestyle factors, other seasonal factors that can affect it, but also some laboratories have different experience with checking very, very low sperm count. So when there's really no sperm count on the first kind of gross measure, we do what's called a pellet, and that's where we take the whole ejaculate volume, concentrate it to a very, very tiny amount, so we're really concentrating everything that's there. So if there are a few sperm, it makes it much easier to identify. So you want to make sure that, again, the laboratory also has some familiarity with the condition.
The reason why I'm saying that is because some of my clients have had that experience of getting the call that there's absolutely no sperm, and then to retest again, it's for me, how I explain it, it's like a selfie, right? You're just taking a sperm selfie at that moment, and just like if you go someplace else and take a selfie, it's going to be different.
Right.
And would that be an accurate way of describing it?
Yeah. No, I have seen some men with wild fluctuations. So, testicles are outside the body because they need to be cooler, and so anything that warms things up can be a problem. So I had one man that had a good sperm count, and then all of a sudden it went to 0, and it turns out that he had a really bad flu, really high fevers, and his sperm count went to 0. We gave it a few months, it came back to normal. So I think that, again, we want to, it can be somewhat dynamic, so we want to keep a close eye on it, but do repeat it.
Well, the reason why that's so important is because when you hear that information, your whole system goes into fight or flight, right? Like there's a problem, oh my gosh, especially if you've been trying, and now the gentleman or the man is getting evaluated, and then you get this news. So I'm just trying to, quiet that part of, 0 to 100, that let's just, have another retest because it could be different.
Right, absolutely. And I think that, obviously to hear you have no sperm is devastating. I don't think there's any question about that. But I think it's not hopeless. And it doesn't mean that you're sterile. I think techniques can definitely be done to help you have a biological child. So I think that's very important to hear about as well.
No, that
I think it's also important to talk about second opinions. Some people will jump to conclusions. Okay, this is what it is. And now you have these options, and not really taking the time to understand it. And I feel that it is important for someone to listen to the advice and do a second semen analysis, get an underlying diagnosis of what's going on to figure out if they do have options.
Yeah, absolutely. I've given second opinions for patients. I know some of my patients have gone for second opinions to other providers, and I think it's very reasonable just to hear other people, even if they're telling you the same thing. I think it's a big deal. It's a very important part of life. So I think that you should get as much information as you can.
So can I ask you another question? When you talked about, that the scenario of the dad saying, well, in 30 years it'll be different, right? So I've been around in the fertility, it's an industry now for a while, and there's such leading technology about going in and finding, I think, Sarah, what was the word, pocket full of sperms, or there's other ways to access sperm when you determine you are producing it in case there is a blockage. Is that correct?
Yeah, so what we do now, if we do think there's a production issue, what we do is look inside the testicle to see if there are some limited pockets. And so we found that if we use a microscope, we can identify these kind of little pockets inside the testicle where some of the components of the testicle are more likely to produce sperm. So they tend to run with blood vessels, tend to be a little bit larger, a little bit thicker, a little darker, and so that can be where sperm is, whereas other parts of the testicle don't have production. So the testicle is very heterogeneous. In other words, if you look kind of at one spot, it doesn't mean that's reflective of what's going on everywhere else. So you just want a very kind of comprehensive view, and the microscope really allows us to do that very systematic way and very safe way, because we can just minimize the amount of tissue that needs to be removed. We can be very kind of efficient in just getting the sperm, but kind of minimizing trauma to the rest of the organ.
That's so important, because getting that news of the test results, there's just so many options too. You still have choices, and
right.
that I love that word, pocket full of sperm. You know, I love that.
Yeah.
I know that sometimes obstructive things can be caused by things like infection. Is that how common is it that an STD or an infection or something like that would block off?
Yeah, I think we do see that a lot, and a lot of times men do have a clear history of it. They have something called epididymitis, where there's an inflammation in the scrotum that leads to a lot of pain. Treated with antibiotics, everything calms down. So even though the active infection is gone, there can be still a lot of scar tissue. And sperm is made in the testicle, and then it matures in this structure called the epididymis, which sits just on top of the testicle. And then from there, sperm goes to the vas deferens, and then up into our bodies, and eventually out, in the ejaculate. So the epididymis is this very fine tubule, and so if there is this big inflammatory process during an acute infection, whether it be from sexually transmitted disease or other form of infection, even though everything is settled down, the infection is gone, there can still be scar tissue. And these tubules are so delicate, it doesn't take a lot to block them. So I think it's very important when we're talking to men with this diagnosis, again, to get a good history, to find out if there's anything like that that's happened in the past. Because if there is a blockage, again, that's a reasonable prognosis. We can definitely get sperm, and hopefully we can actually do surgery to correct it. If we can identify the site of blockage, we can redo some plumbing, which is what urologists do pretty well, to eventually get sperm to go where it needs to go.
I think the other message there is that I hear from you, which kind of echoes the rest of our week, is that if you do have an infection or you have a problem, get it treated, because you could be preserving things later on down the line and not have to go through this trauma and stress of having an azoospermic result and then subsequent surgeries if you just treat it now. With your antibiotics and stuff.
Yeah, I think that's an excellent point. Yeah, just don't. If your body's trying to tell you something, don't ignore it. Definitely listen to it. Go to your doctor, get it looked at, and because there could be implications down the road.
Doctor, you have time for one question?
Yes.
Okay, and then we know you have to. So the question is there any hope of reproducing if a man was born without one testicle?
Yeah, that's a good question. So obviously it's a paired organ, so one should be enough. Obviously the reason that you were born with, or the reason somebody was born with just one, you have to find out why that was, because sometimes if there is a problem with development, it can affect the other one as well. But in general, I think that things should probably be okay. I think that would be somebody, early on in the journey, you should get a sperm count. So in other words, I probably may not want to wait a full year. Again, if there is some kind of underlying concern. But one testicle should be enough. We know that men that have lost their testicle to trauma, lost their testicle when one was undescended and during surgery had to be removed, or cancer, those men can still be fathers. And obviously, a lot of times without any assistance at all. Their sperm counts are totally normal. So I think that I would be optimistic if that's the only problem.
There's a follow-up portion to this, and it's the woman of the couple asking this, and it says his parents told him when he was very young he had no chance of having children, and I think that brings us to back to the time within this industry and the changes within it. So can you just address that?
Yeah. Well, I don't know where. I don't want to speak bad about anybody's.
No.
But I don't know where that information came from. So I think before you get that kind of diagnosis, that's, I think, a great point. We talked earlier about second opinions. I think I would definitely go talk to somebody and see what they think and check a sperm count and see where everything is, because 30 years ago, I think our technology was not where it was today. There's been really revolutions in modern reproductive medicine, from in vitro fertilization, with intracytoplasmic sperm injection, where we can actually just take one sperm, inject it right into an egg. Those are just marvels, and they really lower the bar tremendously about how much sperm we need, how much sperm a man needs to become a biologic father. So I think for those reasons we're in a much different place. But again, if a man just has one testicle, that's not necessarily a huge problem. So I think I would just get more information, and I would tell him to to seek a consult with a reproductive urologist or a urologist, or even his primary care doctor, just to start of a basic evaluation to see kind of where he stands.
And how common is that, doctor?
To be born with one testicle?
Yeah. Is there?
Yeah, I think probably, I would say maybe around 1%, maybe a little bit less.
Okay. I was just trying to help him feel like he's not, he's not alone in this because.
Yeah. But if you have only one testicle that you can feel, the other testicle could still be up in the body. So I think that you should make sure, again, for health reasons, that has been thoroughly evaluated, because there are some conditions where it's in the body, doesn't come down, but it still is kind of a risk. So it's not something that should just be ignored.
Okay, thank you so much.
Mm-hmm. So this is great. Thank you.
This has been an amazing conversation. I think just to revisit some of the main points. One, the news of azoospermia is the line. It's the beginning of a new journey. So 2, you're not alone. And 3, it's important to get second opinions and really to find out what's going on underneath everything. Doctor, if someone is listening and they are just really have in their gut that they want to get a second opinion, or they want to hear from you what they might do next, how can they get a hold of you?
I think the easiest way is probably to email me, which is just my last name, Eisenberg, @stanford.edu.
Perfect. And of course, we'll put that up on the website and the follow-up information after the summit. If you're having a difficult time, just go to the landing page of the summit. But we'll help you get to Dr. Eisenberg. So thank you so much for your time again, and it's such an honor to have you again with us this year, and we so appreciate your time.
Absolutely, my pleasure. Thank you.
Thank you.